15, 20, 25 minutes, whatever time is left for, feel free to ask any question about this topic. So hydronephrosis is basically aseptic dilatation of renal pelvis and calyces, which can be physiological or pathological. It can be non-obstructive dilatation or obstructive dilatation, such as because of well-hydrated patient, increased renal urine output, you can have a physiological dilatation. In fetuses, there is physiological dilatation of the pelvic system. And in VOR, a lot of times you have pelvic dilatation. Because of high pressure bladder, you have pelvic dilatation, which is basically not obstructive at the level of pelvic junction obstruction, or not obstructive at all. So what is called pelvic junction? When any impedance to the flow of urine at the level of pelvic junction, which can cause gradual and progressive damage to the kidney if left untreated. This is the one which will be called pelvic junction obstruction. But the dilemma is how to diagnose it. It's not easy to diagnose. So in the next half an hour, 45 minutes, we will definitely try to work on it, that how best we can diagnose and how can we discriminate those who can lead to gradual and progressive damage to the kidney if left untreated, and those who are not destined to cause any damage to the kidney and should not be managed surgically, or those who need observation. So it is one of the commonest congenital abnormalities of the urinary tract. Majority are discovered now these days in the developed world. About 80% are picked up prenatally. Here as well, the trend is picking up that people going for routine gestational ultrasound, the ultrasonologists, the obstetric ultrasonologists are getting expertise that they look at the urinary tract and they pick up these hydronephrosis, and then they refer to pediatrician, pediatric nephrologist, pediatric urologist, or urologist for opinion. And it is so common that it is found in 1 out of 1,500 pregnancies. The gender bias is there. There's more male, 2:1 ratio. It's been seen consistently that it has been, the PUJ affects left kidney more than the right. About 10 to 40% of these cases can be bilateral. A little bit about etiology. Broadly, the etiology is divided into intrinsic and extrinsic lesions. The commonest are usually intrinsic, and of them, mechanical obstruction is, again, is the usual one which we find, where we have this stenotic segment at the upper end of the ureter or at the level of pelvic junction. But at times you may not find it obstructed, or you can have a combination of the two. That it is a neurological, it is not a neurological abnormality. It is an abnormality of the muscles of the pelvis and pelvic junction obstruction, and the abnormality of the peristalsis. So it can be a functional obstruction at this level, that it is inability of the peristalsis to proceed beyond this, or at times it is combination of the two, that this distal part of the pelvis can have a poor muscle and there is a obvious stenotic segment, and then the rest of the uterus is fine. There can be a lot of extrinsic lesions, like commonest one is aberrant vessel. The lower pole vessel crosses anterior to at the pelvic junction, and that can cause permanent or intermittent obstruction at this level. There are a lot of theories about it. It can be combined.
गोनेडल को लगा दिया था आपने? नहीं, गोनेडल मैंने अभी पहुंचा ही है। ये दो क्या लगे हुए हैं? ये तो मुझे तो लग रहा है ये गोनेडल तो नहीं ओपन हो रही है।
Well, so these are the one which are the extrinsic obstruction. Some debate that whether it is cause or effect, or at times it is a cause as well as an effect. What I mean by that, it is causing intermittent obstruction, and that intermittent obstruction gradually leads to dilated pelvis. And then this dilated pelvis get kinks, and it finally becomes permanent obstruction because of the aberrant vessel or high ureteric insertion. And then you can have the secondary obstruction. You see this secondary obstruction a lot of times in cases of VUR. The reflux causes dilated system, and then finally there is a kink, and that kinks become permanent, adhered because of some adhesion, and that leads to secondary pelvic junction obstruction. We are talking about congenital hydronephrosis. Of course, there are other secondary causes of pelvic junction obstruction because of surgery, because after pyeloplasty even, or stone surgery or other surgeries at this level. We are not talking, I'm talking of congenital secondary obstruction, which is associated with VUR usually, and high-grade VUR. So what is the pathophysiology of pelvic junction obstruction? I'm sure you people are getting more and more informative about the lower tract urodynamics, but I think people don't know that there is upper tract urodynamics as well. And this upper tract urodynamics plays a big role in pelvic junction obstruction. It behaves in the same manner that when the renal pelvis is filled, when the renal pelvis is filled, it fills ultimately to the capacity, whatever. It depends on the compliance of the renal pelvis and the pelvic health system. It fills, and then when it reaches its capacity, there is a rise in pressure. So it is not just the severity of the obstruction, it is the compliance of this pelvic health system, particularly the pelvis. And you know very well, you must have seen in imaging and you must have read that there can be variety of renal pelvises. They can be completely extrarenal, they are intrarenal or combined intrarenal extrarenal. And they have different level of compliance because of the muscular wall. And so this can be variable. The compliance of this pelvic system can be variable. And intrarenal pelvis can have a very small capacity, and it can overdistend, and it can have a very high pressure very quickly, or a large extrarenal pelvis can accommodate without having a rise in pressure, and the distending pelvic the calyces and damaging the cortex. So this concept is very important in managing the pelvic junction obstruction. And looking at the ultrasound, diuretic scans, with pressure flow studies or follow-up of these cases and deciding for surgery, this concept is very important. I don't want to belabor it at this moment because I can spend the whole hour talking about it. Coming to clinical presentation, as I already mentioned, that these days, majority of these can be picked up on routine gestational ultrasound, and they are prenatally diagnosed. So there are no symptoms, and then they need to be followed up. That's an advantage, actually. In the past, when there was no prenatal diagnosis, a lot of, even now in our countries or developing countries, where there's no universal facility for prenatal ultrasound, or the ultrasoundologist, obstetric ultrasound doesn't look at it properly and they miss it, or they don't report it, or the patient or the lady doesn't register it, and they present late with the damaged kidney. So this is a kind of double-edged sword, actually, where what happened, and we'll talk a little more about it in the next slide. Let me just get on to the other presentations. And then the symptomatic presentation can be in infants, where usually those are picked up by parents. Either the child is crying a lot and they go for abdominal ultrasound on the basis of suspecting something wrong with the tummy, and then there's an incidental finding, or there's a classic palpable big hydronephrotic mass which on ultrasound is cystic, and then you suspect that, okay, this is a pelvic junction obstruction. No, We'll talk about it a little later, what are the findings on ultrasound. Or rarely, the child can develop UTI, baby can develop, or neonate can develop, infant can develop UTI, hematuria, failure to thrive. It is less common if it is a unilateral pelvic junction obstruction. Let it be very severe and damage the whole kidney. If the other kidney is fine and the creatinine maintained, this is usually not the cause, but these are the reasons when parents take them to pediatrician and pediatrician ask for an ultrasound and they are incidentally picked up. Sepsis and residuemia, these are less common for presentations, but for various reasons, they go for ultrasound and incidentally pick up. Later in life, yes. When bigger children, of course, the commonest presentation is their episodic abdominal pain, because in small children, there is no localization of the pain. So they complain of vague abdominal pain. But the bigger the child, there is more and more localization of the abdominal pain, and the pain is localized to the flank. And it's very obvious that, okay, whenever there's a flank pain, they go to the doctor. And it can be sometimes so severe that they have to go to a doctor in an emergency and they get injectables for pain relief. It doesn't go away on its own. They start having vomiting because of severe pain. And this is the other reason that they develop UTI. About 30% of children are picked up on the basis of repeated UTI, which includes female more often. And then occasionally they can have hematuria with some trauma or without trauma. So these are the usual presentation of a child with PUGO. So 80% in the developed world are picked up prenatally, and the small children are usually picked up incidentally or otherwise with a large hydronephrosis, palpable mass. Then later on during life, abdominal pain, intermittent pain, or UTI or hematuria. Let me talk about it. When you're talking of children with abdominal pain, one should not just think of PUGO. They can have abdominal pain, particularly when you go for an ultrasound and all other things, and you don't find hydronephrosis or significant hydronephrosis. One should exclude or take more detailed history about their bowel habit. A lot of these children are constipated. Part of the world is another very common finding, which lead to all this pain in abdomen. So deworming or history of worm infestation is of great importance. So coming to prenatal hydronephrosis, kidneys are visible on ultrasound around 14 weeks of gestation. And usually an obstetric ultrasound for anomaly scan, which is called anomaly scan, is asked around 16 to 20 weeks, usually around 20 weeks. And this hydronephrosis can be picked up if it presents early, or so it can be picked up, or definitely kidneys can be seen at that time. So one should look for these kidneys. Any obstetric ultrasound should look for urinary tract abnormalities and look for these hydronephrosis. The two kidneys can be seen like this, and this is another angle where you can see the hydronephrotic kidney. The left kidney is on the side of the heart, so that's how you pick. Sometimes it is not easy to pick it up. Then the other findings which are related to the urinary tract, that one has to look for the amniotic fluid, particularly when you have bilateral hydronephrosis. Then the relevance of the adequate or inadequate amniotic fluid becomes very important. What happens when they pick up these hydronephrosis prenatally and they refer them to you for opinion? So you have to judge that severity of hydronephrosis is important. It can be physiological. So this, what I was talking about, that prenatal diagnosis was a double-edged sword, that on one hand, it started picking up these pelvic junction obstruction very early, so that they can be treated very early, and then that prevented renal damage. But at the same time, it created a lot of anxiety, and then it took some time for the perinatal urologists to develop criteria, standardize it, to discriminate between those which are physiological, non-obstructive dilatation, and to counsel the pregnant mother about the fetus. Now it is well developed, so I think all of you and us should know about it, that if it is not very severe, it is a smaller dilatation, then, and even otherwise, one has to tell them that if it is unilateral, and how is the cortex, how is the other kidney, if the amniotic fluid. So there's no need for prenatal intervention in cases of PUGO. Even if bilateral, it doesn't give any advantage. So the best is to counsel them, reassure them. Of course, depending on the severity, you once you have an understanding, you can counsel them better that the best thing they should do is to come for follow-up postnatally. And the guidance for the obstetrician should be that they have to deliver the baby according to the obstetric need. There's no urgency of delivery, or there's no urgency of asking for a cesarean section on the basis of a baby having hydronephrosis or periaortic junction obstruction. They should go full term. They should have a normal vaginal delivery. That's the kind of help you can create. But definitely, depending on the severity of hydronephrosis, what you need to guide the parents as well as the obstetrician, that they need to be followed up postnatally in any hydronephrosis. So how to diagnose postnatally? This I have purposely kept it that you need to take a detailed prenatal history. If you have picked up this prenatal hydronephrosis very early, it gives you a better idea about the pathology, and you can judge better that which case will need surgery, which case will not need surgery, or you can keep them under observation. One of the fact that the parents are so anxious, or the doctors are so anxious, they refer you very early, even in unilateral hydronephrosis, and such as this 4-day-old baby girl presented to us with an ultrasound on day 2 with a 6 millimeter epidiameter. One of the things which I want to highlight here is that the day 2 ultrasound in this case is not very useful. What happens that the babies born are usually dehydrated. And then when they are dehydrated, the day 2 ultrasound can show a very minimal hydronephrosis, which may be actually with adequate hydration more than this. So one has to repeat. So that if it is a unilateral hydronephrosis and the contralateral kidney is normal, you have to guide them that they don't need to rush from the hospital straight away to a perinatal urologist. They can come after a week when the mother's gone home, and then you should repeat an ultrasound at least after 72 hours with well-fed baby, the breastfed or bottle feed, whatever. The baby should be well-fed, and then ultrasound has to be repeated. I can give you a couple of scenarios that what can you get. Supposedly, this patient, this fetus had at 20 weeks normal bladder and amniotic fluid and 2 normal kidneys, and 32, 34 weeks there was. They usually do it at 20 weeks for an anomaly scan, and at 34 weeks for the lie and presentation and obstetric needs, when to deliver the baby. So they do it at least 2 routinely gestational ultrasounds. So these are all routine ultrasounds, gestational ultrasound. And the left renal pelvis measured 7 millimeter, no chalazial dilatation. So then this is not that significant. If it is done, so you don't have to create any anxiety. But if this patient who at 20 weeks already had 10 millimeter, and at 28 weeks the dilatation increased to 22 millimeter, and 36 weeks it increased to 20 millimeter, then this is more suspicious. So that's why the prenatal details of the prenatal ultrasound are so important. Usually they don't bring the record. You don't ask for it, so you have to ask for it, and they have to keep the record and try to gather that information. Prenatal ultrasound history is so important. So these 2 presentations tell you about that this is likely to be a physiological, and this is likely to be more pathological. And similarly, postnatally, when the 2 comes, what happens? That this was only 10 millimeter. and no calyceal dilatation, as expected. And the other one, which was already 28, again 28 millimeter with moderate calyceal dilatation. This is a suspicious case. This is a more severe case, and this is with a parenchymal thickness of 8 millimeter, which is much less than it is usually, normally is 1.5 centimeter. So this will need further investigation. This need can be observed. So how do you standardize these ultrasound? So there are two ways of looking at it. One is Society of Fetal Urology, which grade these hydronephrosis, grade 0 to grade 4. Grade 0 is no splitting, it's a normal. Grade 1 is again very minor, which is pelvis splitting of sinuses. And grade 2, urine fills extrarenal pelvis and major calyces dilated. From here, they start becoming suspicious. This is grade 2. And then grade 3 is, of course, extrarenal pelvis, major calyceal dilatation, including minor calyceal dilatation. Minor calyceal dilatation. This becomes suspicious. And grade 4, where you have parenchymal thinning, but how much thin, they don't calculate, they don't measure in these. So it can be very severe like this, it can be this, both of them are grade 4. But this is one way of standardizing the hydronephrosis in cases of PUGO and findings. The other is you measure anterior posterior pelvic diameter. It is measured at the level of hilum in the transverse plane, the anterior posterior pelvic diameter, APPD, at the level of hilum in the transverse plane, at the level of hilum in the transverse plane. Unless you have a standard place to measure, the measurement will vary, and then there will be no standardization. So this technique is extremely important, that one should know where they are measuring anterior posterior diameter at the level of hilum in the transverse plane. It can be 5 millimeter, 10 millimeter, 15 millimeter, which are insignificant. And then from there, 20 millimeter, 27 millimeter, 35, what can reach up to. So this is the way to measure APP diameter. But actually, both of them have limitations. As I mentioned, that here, both are grade 4, grade 3, grade 4, but the difference in cortical thinning is different. Similarly, the AP diameter is less here, but this has damaged the kidney because it was an intrarenal pelvis. The AP diameter was less, but calyceal dilatation grows and there's the cortical. So AP diameter doesn't take into account the cortical thickness. Here, AP diameter is much bigger, and this has also damaged the kidney. So one of the best way is that you combine the two and you measure all these things when you are looking at a kidney with hydronephrosis and pelvic junction obstruction on ultrasound. You have to measure the length of the kidney because it has to be longer kidney because of hydronephrosis in PUGO as compared to the contralateral kidney. One has to measure the calyceal dilatation, mild, major, severe, house. Pelvic dilatation, it is better to measure in APVDD. Then parenchymal thickness is important. Its echogenicity is important. If it is dysplastic kidney with increased echogenicity, then there can be poor functioning. Then you have to look for the ureter and it has to be done in full bladder, adequately hydrated. When you do it for full bladder, you can look for distal hydrated. If you have distal hydrated, then it is not PUGO. It can be reflux, it can be UVGO, it can be combined pathology. So looking at these features are very important. The next step in diagnosis and alleviating that dilemma, that which is that obstruction which is likely to lead to renal damage if left untreated, is the diuretic renography. There can be a variety of isotope scans, as you know, that DMSA scans, DTPA scans, and MAC3 scans. Usually, DTPA was the first one which was used as dynamic scan for diuretic renography, and then because when the MAC3 came in with the better images, it has taken over. And conventional isotope scan was not a diuretic scan, and then forced diuresis was introduced, and then timing of diuresis were changed. Initially, in the diuretic scan, the furosemide was given at 20 minutes, which was called F20. Then they introduced, there were a lot of equivocal cases with partial clearance. So in order to reduce that equivocal cases, they introduced the concept of F minus 15 because Lasix take 15 to 20 minutes to work and to produce diuresis. When we were giving at 20 minutes after radiopharmaceutical, and Lasix used to take 15 to 20 minutes, then the real effect came later on, and the clearance curve had already done. So a lot of them were not producing enough diuresis. Particularly, that was the problem with large extrarenal compliant pelvis, is that they did not fill up to capacity. If you know about the Laplace law, that unless the pelvis is filled to the capacity, it will not contract, or peristalsis will not generate. So it will not contract to pass urine across pelvic junction obstruction. Then nowadays it is basically F0. And when we talk of diuretic scan, there are three parts. Perfusion curve. Perfusion is 30 to 1 minute. When the radiopharmaceutical is given, it goes to the renal vessel. And then uptake, when it is taken up, this is a dynamic scan, or that means you are doing a functional study of this, not just the relative function or imaging. Just like ultrasound, morphological appearance, you were seeing morphological appearance in ultrasound. You can do, of course, a furosemide-induced ultrasound, but that is not usually recommended. The best test which is being done to assess the functional part of the dynamic scan is the diuretic renography. So this is the uptake portion, and then the clearance portion. When the contrast has been taken up by the parenchyma, radiopharmaceutical has been taken up by the renal parenchyma, and then it starts clearing up into the calyces and the pelvis, from the pelvis into the collecting system, into the ureter and the bladder. So it is one of the most commonly used tools to assess obstruction, gives good differential function as well between the two kidneys. It gives relative function because the combination of the two, if you add the differential function of the two kidneys, it will always be 100. So if there are two poor kidneys, they can be 50-50. If there are two good kidneys, it will be 50-50. So just the number doesn't matter, and there are other flaws in it that sometimes the software is not good. You cannot subtract the background activity, or it is a dilated system which is the stasis. So there is a lot of overestimation. And then even in a poor kidney where the radiopharmaceutical has not cleared from it, so the number doesn't give you that much information. So you have to look at the graph. You have to look at the images, which I'll talk about it a little later. So one of the ways to see the clearance is T half. That's the half time required for the clearance of 50% of the radiopharmaceutical. The time required for 50% of the radiopharmaceutical to clear from the system, the time required, which is usually up to 10 minutes, less than 10 minutes. And if it is more than 20 minutes, it leads to obstruction. There are two sites from where they can measure. Either they look at the T half when there is a steep descent of the curve, or they start looking at it. So these are minor details. I don't want you to bother about it, but I just wanted to highlight that there is a lot of controversy about it, and particularly in children. So, but this is one of the way to assess the clearance. This is T half. The time required to clear 50% of the radiopharmaceutical from the system, right? And the other way, which you are more familiar with, is to look at the clearance curves. The clearance curve. Both the kidneys are clearing. The red is the left and the blue is the right, and this is perfusion. The renal vessel took 30 to 50 minutes. And then this is uptake of the parenchyma, and once the system has start draining into the pelvis, and then this goes into across the pelvic junction obstruction. So it depends on the area of interest in the where you put the area of interest when you are doing a renal scan. In this, left kidney is reduced function. There is less uptake, and it's not clearing up. There are a lot of fallacies of this diuretic scan. The patient has to be well hydrated. Of course, there should not be any bladder outlet obstruction, or the bladder should be empty, or you can. And then in poor functioning kidney, there can be uh, some difficulty in assessing this clearance curve because uptake is so slow and it doesn't excrete, so the curve can be partial clearance because of poor functioning kidney. And these are good kidneys. This is a diuretic response to these kidneys. So what we should do when we are looking at the diuretic scan, that we should not just look at the T-half or the clearance curve, we should look at all the things. And images gives you a lot of information. Left kidney has delayed perfusion and uptake, delayed uptake. The right kidney is already started clearing up, and it is coming into the bladder from the pelvic junction. It is picking up the left kidney. So that gives you an idea that there is some obstruction at this level. And even at the end, there is stasis in the pelvic system or the pelvis. So one has to look for at the images, the clearance curve, and the T-half. So all these things, when you assess a diuretic scan, you should look at all the three things. When it's a very reduced functioning kidney, or the parenchyma is, which you can see on ultrasound, that there's a thinned out parenchyma, and you want to decide between whether you want to retain this kidney or the kidney is completely gone, you may have to take out this kidney or perform an nephrectomy. Maybe a diuretic scan is not a good idea. You should go for a static scan, which is called DMSA scan, because it gives a better idea of any relative residual function. It just stick to the parenchyma. It slowly is there's a slow uptake and it goes. There's no clearance in the routine DMSA scan. So any functioning parenchyma, it will show. It takes 2 to 3 hours for this to pick up. Finally, I'm just mentioning intravenous urogram as an imaging investigation to tell you that it was historically one of the most important investigation to pick up hydronephrosis and pelvic junction obstruction, and people used to pick it up. This is a normal kind of a system where the first effect is blunting of the calyces, and then usually they are cup-shaped. And then the first effect of obstruction would be the minor obstruction or the kidney is good cortex, is that there is flattening of the pelvic fornices. Then they will become club-shaped, and there is some reduction. In severe cases, there was no excretion into the system, and you needed delayed films, or you just used to see the nephrograms, and this is in the calyces, which is called calyceal crescents. And then this has not even come into the calyces. This is collection of contrast into the dilated collecting ducts, which is called lacunae or sign. So nowadays intravenous urogram is not recommended for various reasons. Firstly, there is contrast nephropathy, there is radiation hazards, much more than isotope scan, and it doesn't give you that information, and you need to wait for many hours for delayed films. For all these reasons, intravenous urogram is no more recommended in cases of pelvic junction obstruction. You can get some information when you have complex pathology like horseshoe kidneys, or you have a duplex system where you can ask for it, but otherwise it is not needed. So you can see that if you have an ultrasound which is showing you good hydronephrosis, you can measure AP diameter, you can look at the calyces, you can measure the cortical thickness, and in a normal kidney and hydronephrotic kidney differentiate, and you have an isotope scan, which is diuretic renogram, you get enough information to take a decision for it, for the management. So actually, you don't need an IVU in most of these cases. What other investigations, particularly in cases of pelvic junction obstruction, very rarely, because it is an invasive test, and in children it needs anesthesia, so it is not routinely done, which is pressure flow study or perfusion, pressure perfusion studies. One of the famous tests is Whittaker test, a variety of ways of doing it. You can keep the flow consistent or you can keep the pressure consistent, but it is done under anesthesia. You have to have two needle in, one interpelvical system and one in the renal cortex to measure the pressure differences. You have to have catheter in the bladder, and it starts with a 10 ml, and you can increase the flow rate up to 50 ml depending on how compliant the renal pelvis. In poor functioning kidney, where you cannot get an idea with the diuretic urinogram, sometimes you need this invasive test, and it is done with the help of fluoroscopy, so you can always see the images as well as you can measure the pressure in the kidney and the pelvic system, and then which can give you an idea whether it is obstructive or non-obstructive in equivocal cases. It is if you already have a nephrostomy in, then you can do it. And sometimes the patient comes with severe hydronephrosis or paranephrosis, and you have placed a nephrostomy, you have drained it. And once you have a nephrostomy in, you can do an integrated pyelogram, or you can measure the pressures as well. So in those cases, it is much more useful. CT, control CT or CT KUB or CT urogram. CT urogram carries a lot of radiation and contrast hazards as much more than IVU, so it is not usually recommended. The only recommendation when you are doing an endopyelotomy in these cases and you want to look for an aberrant vessel, this is one of the best investigation which can give you an idea, unless you ask to them that we want to have a vascular phase where we want to see a lower pole vessel crossing anterior to the pelvic junction obstruction. And the plan is, and I'll come to management and then I'll tell you the need for endopyelotomy, which is very rarely done in children for primary congenital pelvic junction obstruction. So CT urogram is again very rarely needed or recommended. The other investigation can be MRI in developed countries where the MRI facility is easily available, or in bigger children who can do it without anesthesia. Otherwise, you need an anesthesia for MRI in most cases, so that's why it is not recommended. But this image tells you the level of obstruction in this case, with the help of MRI. Certain biochemical markers have been used for research purposes for prenatal diagnosis of PUJO and later on, but the specificity and sensitivity is so less that they are not of any practical importance. They are basically for research purposes. The research is ongoing, maybe in long term. They are diagnostic, but at the moment, at the most, they can tell that there's some element of obstructive uropathy, and there's some cytokines or growth markers which are excreted into the blood. So coming to management, which case would need conservative management, observation, and which case would need a surgical management? So this algorithm tells you, so any unilateral hydronephrosis where AP diameter and no calyceal dilatation is less than 15, so you do ultrasound after a week or 72 hours at least with well hydration, and if this is the finding of less than 15 millimeter, then you repeat an ultrasound in 1 month, then 3 months, 6 months, 9 months, and 1 year. Once it is at 1 year, it is the same, then you can ask for a yearly ultrasound. In these cases, you cannot ignore them because there have been reports that even these minor cases have shown dilatation later on in life and presented with PUJO, but very rarely. So most of these cases just need 1 year follow-up and then yearly follow-up. But those who have PD or anterior posterior pelvic diameter of greater than 15 millimeter with calyceal dilatation, and you have to repeat an ultrasound in 1 month, and then with in these cases you have to do an isotope scan at 4 to 6 weeks because you need to have some maturation of the kidney before you ask for an isotope scan. There's no point in doing an isotope scan before 4 to 6 weeks, preferably 6 weeks, because that takes until the kidneys, you don't get the right information. So after MEG scan or diuretic isotope scan, the kidney is good functioning. That means more than 40% is the cutoff. If it is more than 40% functioning, again, I will tell you, as I've mentioned, you just don't have to go to the number. You have to look at the images, whether it is an overestimation or not. I'm not talking overestimation. It is a true estimation is more than 40%, then ultrasound at 3 months in a good functioning kidney, because it has not reduced in function. That means obstruction up till now has not been severe enough, but we don't want it to suffer. So we will continue to look at with a simple investigation, which is ultrasound 3 months, 6 months. If it is increasing hydronephrosis, then we will definitely go for further management, depending on how much increase is there in the hydronephrosis of calyceal dilatation. And then 1 year again, we can repeat a MEG scan if there is, particularly when there is some increase in hydronephrosis. But if the kidney has reduced somewhat in function, particularly if it has less than 35% function, then depending on, it is one of those cases who would require early surgery because that means this obstruction, there is already some evidence this obstruction in the past have damaged this kidney. So this is the group which is actually we have to focus on, that a lot of them may be saved from surgery, and but if the pelvic diameter increased to 30 millimeter, there is reduced function, or there are symptoms. Again, symptoms will become, once the patient is symptomatic, that becomes a very important part in decision making. And you, as I mentioned earlier on while presenting the symptom, that you have to be very sure that the symptoms are due to pelvic junction obstruction, not because of worm infestation, not because of constipation, or it is not a radicular pain, musculoskeletal pain, which increases on activity. So some of the intermittent hydronephrosis are difficult to pick up. So one of the ways is to ask them to get an ultrasound when they are in pain, or they are equivocal cases, but it is difficult for them to come again and get investigation. And the tilt is toward they will need surgery. You can recommend surgery because of the socioeconomic consideration. People to us, they come from far-flung areas, it is for them. So if there's a strong evidence that they would not need surgery, that's our gut feeling, then we will not. But if the gut feeling is it is 20 millimeter, 25 millimeter, some calyceal, mild to moderate calyceal, then they will be, even if there's a good function, we don't want it to deteriorate, and we would like to have recommend surgery in those cases. But the basic recommendation would be on the basis of there is no need for MEG scan when the APDT is less than 15 millimeter. It's only recommended when it is more than 15 millimeter and no calyceal and some calyceal dilatation. So there's some data from Great Ormond Street, London, that those with less than, as I've already been emphasizing, the less than 15 millimeter, only 2% needed surgery. That's why I said there have been some reports who culminated into bigger, greater hydronephrosis and PUJ obstruction, and they need surgery after 1 year or so. So they need to be followed up for 1 year and then yearly follow-up, or when they have symptoms. 15 to 20 meter, again, only 11%. It is 30 millimeter or more who require, if it is more than 30 millimeter, then 90% would require surgery. Or 40 millimeter or 50 millimeter, the majority of them require pyeloplasty. So this is the group who would always require 20 to 30 millimeter AP diameter with calyceal dilatation. If it is mild, you can observe depending on their socioeconomic status, depending on the symptoms. If they have symptoms, then you have to do them early. Only 40% required surgery. So those who were under observation, hydronephrosis resolved in 47% and hydronephrosis improved in 33%. Of 20%, those who were under observation, out of 36 patients, 7 needed surgery. 17 got resolved and 12 improved. So by and large, if it is more than 30 millimeter AP diameter, then one has to recommend surgery. Between 20 to 40, they are both ways. 40% would need surgery, depending on symptoms, depending on progression, depending on deterioration function. And then the less than 15 millimeter, or even up to 20 millimeter, you can observe, but less than 50 millimeter, yes, there's very little chance that they would need surgery. In case of bilateral hydronephrosis, you have to be a little more aggressive. That APD diameter is less than 15 millimeter, the same protocol. But more than 15 millimeter, you have to do megascan in all, and if reduced function, early surgery, good function even, then you have to watch them more closely, and then perhaps they would need early surgeries. I want to give you some more time for your question answer, so I'll try to finish it up. As you all know, that those who recommend need surgery, the best is dismembered pyeloplasty, which can be done open. So that you remove the stenotic and the adynamic segment, and then you re-anastomose. There are other varieties of pyeloplasties, but the gold standard is Anderson-Hines or dismembered pyeloplasty. You can do in high uterine resistance, you can do Foley YV, you can do flap. If you have a long stricture segment of the ureter, then sometimes the ureter is short, so it is better, and you have a good extrarenal pelvis, you can drop a flap without dismembering it, and which can be vertical flap or a spiral flap. So these are the recommendations for long stitches. And then this same pyeloplasty, dismembered, or can be done by laparoscopically or robotically. I think in small babies, it doesn't make a lot of difference. It is personal preference of the patient, parents, or you have the expertise and facilities available. In all these open or laparoscopic robotic, when they have the good expertise, the success rate is more than 90%. But in bigger children, a laparoscopy does make, or robotic does make a difference in adolescent or bigger children, because they have muscular body. You need a bigger scar to go in. In babies, you can do it with a 2 centimeter scar, so it doesn't make a lot of difference. And even with open pyeloplasty, they go home in 48 hours. So I don't recommend. Endopylotomy and balloon dilatation is not usually recommended, and it's not practiced. People have done it. They have not found a lot of success with endopylotomy and balloon dilatation. These are for adults, for adolescents, and for secondary strictures of secondary PUGOs. There are always some complication, wound, early complication, late complication, anesthesia complication. The biggest disaster is, of course, when you have recurrence. Otherwise, 95% success rate is reported in most centers. Follow-up, you have to do a follow-up at 3 months, and then 6 months, and 1 year with ultrasound. You can do a renogram at 1 year, and then up to 5 years, you do yearly follow-up, and then you can leave them and try to review them at the time of puberty. So to conclude, there is a tremendous variation in severity and significance of hydronephrosis. The natural history in individual patient varies, and tests are not 100% predictive. You can decide on the basis of ultrasound and diuretic renogram to a certain extent, but they are not 100% diagnostic. In case of mild hydronephrosis, no cholestasis, no parenchymal atrophy, and split renal function greater than 40 in unilateral cases are favorable, and serial observation is usually recommended. Severe hydronephrosis with demonstrable measurable parenchymal atrophy, split renal function less than 35%, particularly if it deteriorates, and unfavorable, these patients likely to require surgery. Serial observations are very important during prenatal period and later part, and particularly in the observation group, and they are very useful. Thank you. Sure.
Great. Thank you, Sajid, for a wonderful, very comprehensive lecture. I'm sure there are questions, and I can read the questions for you. The first one is about
Ahmad,
yes. I'm reading questions for you, Sajid. Can you hear me?
Mute yourself.
Yeah. Can you hear me, Sajid? Am I?
Yeah. Now I.
Okay, fine. So there are questions in the chat box which I'm going to read up for you. So the first question is that in a child, in a newborn who has had prenatally diagnosed hydronephrosis, is there an early ultrasound indicated, meaning within 48 hours?
No, I think I took too much time in emphasizing that to just put it in their mind that there is no advantage, or particularly in unilateral cases, and in most of the bilateral cases, to be honest, are not that sick in cases of pelvic junction obstruction. So a week time is a good time when the baby has been fed properly, it is well hydrated, and then you can judge better on ultrasound, or at least 72 hours.
Okay.
So immediate ultrasound is not useful.
So there is one question about 11-month child who has a 16 millimeter AP diameter. He was an antenatally diagnosed, which was 9 mm at birth and 1.1 centimeters or 11 millimeter at 1 week. His MAC3 at 3 months showed mild resistance, which probably the questionnaire means that there is response to Lasix, but some stasis.
Partial clearance, yeah.
Yeah, partial clearance.
Okay. So the missing information is that when you are looking at the ultrasound, what is the calyceal dilatation? So that needs to be seen. Cortical thickness. I'm sure this kind of kidney would be have a good cortical thickness. If it is mild calyceal dilatation or no calyceal dilatation, then this is not of relevance. And again, the fallacies of isotope scan I highlighted a lot during my presentation, that whether the baby was adequately hydrated, what is the situation of the extrarenal pelvis, how was the bladder, all these things are important. You look at the images. But in any case, this baby would need most likely a close watch rather than, because there is some information about increasing hydronephrosis. So that increasing hydronephrosis makes it a child vulnerable for renal deterioration and worsening hydronephrosis and progressive dilatation. So they need another ultrasound at 3 months. I think this was done at 1 month.
Yes, that's right.
They need an ultrasound at 3 months, and if it is increasing, then you may go for an isotope scan earlier on. If it is not, then you can follow them up on ultrasound only.
There are two more questions about some temporizing diversion, like internal stent or PCN in children who have UPJO and they are pending surgery probably, or they cannot for some reason. So is there any role of these two diversions in children?
Yeah, there is a role when you have a reason. Firstly, if there is a pyonephrosis, then you can do a percutaneous nephrostomy in order to, and very rarely you can have it. In bilateral cases, maybe if they are presenting with renal dysfunction, you can do internal stenting or nephrostomies. But if you are delaying surgery for some hematological or coagulation disorder or something like that, then, or there is another abnormality, anesthesia, prolonged anesthesia risk, then you can do a temporizing measure in such cases. Otherwise, as a therapeutic, you remember, Hamad, in the old days when DJ stent was introduced, there was a lot of pelvic junction obstruction cases where they tried to treat them with double J. And when they took out the double J stent, they all recurred. So it is not for definitive treatment. Yes, temporizing major in special circumstances, they can be used. Depending on the level of sepsis, I would avoid a double J if the child is in sepsis. Or if it's a bleeding disorder, then I would prefer a double J rather than a percutaneous nephrostomy.
So we all know that pyeloplasty, if anything is needed, is the gold standard for the management of UPJO. What is your second line of management if the primary pyeloplasty has failed?
Depend on the child. I think if the primary pyeloplasty has failed, in most cases, they need a redo pyeloplasty. Practically, you can go theoretically, the literature may say that, yes, you can try endopylotomy, you can do a double J stenting, but if it is a stricture severe enough, then they would need a redo pyeloplasty. That is again. But there is a role of endopylotomy in a bigger child and a fibrotic stricture theoretically.
Right.
Or
the
balloon
question about
dilatation and these things.
Yeah. So about poor functioning renal unit with, they have written GFR, probably they meant split renal function of 15%, with the parenchyma looking fairly okay. Is it any point in saving this kidney? I think probably the answer
There's
is
a very important point, pertinent point in this question, that firstly, you can get a lesser function than the actual reserve of the kidney when the kidney is obstructed. So once there is a relief of obstruction, that the real function of the kidney, and as it is mentioned that there's some reasonable parenchyma, which will make us. In any case, now it is no more recommended to remove any kidney with less than more than 10% function kidney. Even people are recommending that any function in the kidney in a child, if you can salvage it, you salvage less than 10% even. But up till now, a lot of people have been recommending you should not remove a kidney which has got more than 10% function. So 15% has to be salvaged by pyeloplasty with particularly reasonable parenchyma.
right. So Waqar Hassan asked that if for some reason in a peripheral hospital, somebody put a double J stent and this child is suspected of having a UPJ obstruction, would you do a MAC3 scan for confirmation with a stent in place or after removing the stent? And for how long do you remove the stent? And then do a study?
Definitely, ideally, it has to be done after removing the stent, and the early the better. But depending on what if it's a solitary kidney, there can be many scenarios. But I think simple answer would be removing the stent and then do it. You can get the information because.
Any role of retrograde pyelography? I mean, I know that the pediatric surgeon used to do retrograde invariably. As adult surgeons, we hardly ever do a retrograde when you have a MAC3 scan. So any role of doing a retrograde in a children before you do pyeloplasties?
Exactly. If you go through the literature, and whenever we used to read about pyeloplasty or PUGO, it was one of the foremost investigation in the past, retrograde urography. But with the advent of modern investigations and ultrasound, and it has been seen that majority have a normal ureter. So one-off case where you cannot have, where then you can't subject a 99% of the cases for retrograde urography. So it is not recommended. And one of the advantage was that you used to know the level of the obstruction. If it is long stricture, short stricture, and you could have given a better incision with a smaller incision. Now people are recommending that you do an ultrasound on table, look for the hydronephrosis site of PUGO on ultrasound, and then give you a small incision at that level. So by and large, the bottom line is, the conclusion is that retrograde pyelography is not recommended or not needed in most of these cases.
So one of the question is that if Professor Sajid Sultan is the examiner, and he asked the question that what are the indications of nephrectomy in a UPJ obstruction, what would be the answer?
Nephrectomy of in a UPJ obstruction.
Of a poor functioning kidney secondary to UPJ obstruction. So when do you, at what cutoffs do you decide that this child needs a nephrectomy? We know that the split renal function is one of the things. Renal cortical thickness is another.
10% function, paper thin cortex, gross hydronephrosis, and a good contralateral kidney, then perhaps in those cases, and a gross hydronephrosis, because the pyeloplasty is not easy and doesn't drain well. So, in these circumstances, I would definitely recommend.
About supernormal function on renal scans. A few words about supernormal functions on renal scans.
Yeah, overestimation, as the word is usually used in these cases. This is one of the reason is that they are poor functioning kidney, and there is hold up of radiopharmaceuticals. And secondly, it is this kind of software you have. If you have a good software and you can subtract the background activity, and they correlate with the images, then the nuclear physicist can give his comment or her comment about the actual relative function or the likely relative function. But the usual report which we see, they just, now I see that some of the report they write that it is an overestimated function. In the past, even they didn't bother to write that. But the reasons are a large background activity, an obstructed system, poor functioning kidney. So that radiopharmaceuticals and the way they have taken their area of interest.
I think prior to the MEC3 scan, which has reduced the background activity, the DTPA was notorious because it would show a lot in the spleen and the liver as well.
Yes, so, because this gives better images now. So you can compare the images as well. One of the advantages of MEG-scan is that it gives much better images. And that's why people stop doing IVUs, because you can see the level of obstruction with you can see the radiopharmaceutical images of the kidney much better. Drainage at what level?
Do you ever wait until you have opened the child to decide whether you're doing a nephrectomy versus a pyeloplasty?
Yeah, that's, I think, is a very good question. It was not a problem for me. Let me answer it in a different manner. It was not a problem for me because I'm not doing a lot of, and it's very difficult to do a pyeloplasty in a huge pelvis and poor functioning, and it is not usually recommended as well. And one of the contraindications of relative contraindications of pyeloplasty is that gross hydronephrosis and all that. So in open surgery, it is easy. And in poor functioning kidneys, about 15% or 12 or overestimation, when you can't judge on ultrasound, you can't judge how the pelvis is and how is the ureter particularly. In children, the ureter, quality of ureter matters a lot. So we take consent for both. So we may do a pyeloplasty, we may take out the kidney. So that it happens in such cases where there's gross hydronephrosis and a borderline 10-12% function, 13% function kidney, with, of course, very poor cortex. You decide at times on table. And it has become particularly important, and we take that decision much before now, because if we decide for nephrectomy, then we go laparoscopically. And
about the DMSA scan, I mean, if there is no other reason, when do you do a DMSA besides a MAC3 scan in children with UPJO?
I think this goes, I would follow it up with the previous question that
Yeah.
in those cases, we have already done a DMSA scan, which I mentioned in my presentation as well, that you need a DMSA scan in these poor functioning kidneys. Sometimes the relative function is much more accurate. A lot of times it's much more accurate in DMSA scan than TPA or MAG scan. Although I have seen that the overestimation problem is also there in cases of DMSA scan. Not everybody gives you a correct picture, but the images can give you a better idea, just like the image I showed in my presentation. So this is, of course, DMSA scan is much better when you have a very poor functioning kidney. I think I'm answering your question. I forgot your question.
No, the question was that when do you do a DMSA in UPGO?
Yeah, so I told you in very poor functioning kidney with poor cortexes, where you know that clearance will not be of any relevance. The clearance curve will not be of relevance. THA will not be. The only objective is to see whether there is some renal reserve to retain this kidney, or you want to take out that kidney. That question needs to be decided on the basis of DMSA, most likely, and ultrasound.
Right, Sajid, I think these are the questions that have come up so far, and thank you very much for very exhaustive time. And I think you deserve a break of 10 minutes at least, a cup of tea, a glass of water, and then we restart.
6:30.
6:30?
Yeah, that's
Great.
what they mentioned. I don't know.
No, up to you. We can start early if you want to. You're okay.
Let me see. I think 6:30 would be fine.
6:30 would be fine?
Yeah.
Okay, great.
Welcome.
And there have been a lot of chat about thanking you for an excellent talk and wonderful. I think you have covered all aspects of UPJ, and the kind of discussion that it has generated in the chat box is really very, very encouraging. And I'm sure if UPJ has the PUB is going to create a barrage of questions for you. So keep at least 15 minutes for question and answer.
I'll try my best to come up to the expectation, but let's see. And it's good to hear from them. They have some such pertinent questions, and